Triple-negative breast cancer is an aggressive type of breast cancer with a poor prognosis. In just 2020, 345 women were diagnosed, and 1/3 of those may become metastatic. And the treatments for TNBC are very limited compared to other breast cancers. For non-metastatic TNBC, traditional chemotherapy is preferred. For metastatic TNBC, there is single-agent chemotherapy, immune checkpoint inhibitors in combination with chemotherapy, sacituzumab govitecan, and PARP inhibitors. There is huge potential in TNBC market as novel therapies are discovered. By 2027, it is projected to reach over $820 million. In order to enter this market, we must target the demographic and areas most at risk, and that includes younger, premenopausal, and/or Black women. And the continents accounting for most of the cases are in Asia, Europe, followed by America. Our Neochuda duo is one of the novel therapies. Let's get into it.
To understand how our combination triumphs over other ones, it is important to understand each of the molecules involved. That understanding should be followed by a comprehensive analysis of the way Paclitaxel and Pembrolizumab's individual characteristics complement each other. To start off, what is Paclitaxel? Paclitaxel is an antimicrotubule agent that affects microtubule assembly by binding to beta-tubulin. This keeps tubulin dimers together and promotes microtubule assembly. This stops the microtubules from fulfilling their natural functions adequately by disassembling adequately and binding to kinetochores adequately. This defect triggers the mitotic checkpoint and stops the cell cycle in M phase. This stop ultimately leads to cell death. However, newer studies also indicate that Paclitaxel affects spindle assembly, leading to daughter cells having inadequate quantities of chromosomes. The latter eventually fail to survive due to an absence of essential chromosomes. In addition to its cytotoxicity, Paclitaxel's anti-neoplasty also comes from its various immunogenic effects. First of all, Paclitaxel activates adaptive immunity by inducing immunogenic cell death. Furthermore, Paclitaxel allows better infiltration of CD8 plus T cells, thus T killer cells, into the tumor and promotes antigen presentation, which allows for better adaptive immunity. Furthermore, Paclitaxel also inhibits immunosuppressive cells and stimulates cytokine and MHC class I molecule production. However, Paclitaxel can also have some dire consequences on the immune system. In fact, Paclitaxel induces PD-L1 expression, which prevents the T cells from activating correctly against the tumor cells. On the other hand, Pembrolizumab is an immunotherapy drug from the group immune checkpoint inhibitors. This monoclonal antibody binds to PD-1 receptors, as you can see in the video in green. In this way, it prevents PD-1 receptors and PD-L1 ligands from associating and thus prevent cancer cells from evading the immune system through this pathway. This way, the immune cells do not recognize tumor cells as self and begin attacking and activating again. Next is a quick overview about both drugs' pharmacokinetics. The most important part to know about both drugs' pharmacokinetics is that both of their dosage regimens can be administered every 3 weeks and that their elimination pathways are vastly different, avoiding placing too much weight on one single organ during elimination. According to us, Pembrolizumab and Paclitaxel are perfect for each other because Paclitaxel, as previously mentioned, has a flaw, which is that it induces PD-L1 expression, which helps tumor cells from evading immune system's attack. However, with Pembrolizumab binding to PD-1, it enables lymphocytes to attack the tumor with full potential. The synergic effect has been shown in clinical trials to be superior to Paclitaxel alone. Furthermore, Paclitaxel's immunogenic cell death allows for the proper functioning of Pembrolizumab, as the latter's action is dependent on tumor-specific immunity. Pembrolizumab's full potential is also unlocked through Paclitaxel's augmentation of infiltration of T killer cells within the tumor. To end this section, we will explore why these two and not others. We chose Paclitaxel to complement Pembrolizumab because doxorubicin and cyclophosphamid's mechanism of action are not perfectly synergic with Pembrolizumab. Cyclophosphamide induces immunosuppressive cells which may reduce the effect of pembrolizumab, and doxorubicin does not affect CD8 plus T cells, which is an important part of the immune system's attack against tumor cells. It is also a vital part of pembrolizumab's mechanism of action. On the other hand, we chose pembrolizumab over atezolizumab because it is much more dependent on PD-L1 expression, which is a vital part in the mechanism of action of paclitaxel.
We know that PD-L1 expression is crucial for immunotherapy to work. Out of all of Tnbc, 20 to 34% of patients have PD-L1 expression, and more than half of them have combined positive score of 10 or more. And these would be the patients eligible for our Neochuda Duo treatment. In summary, the market for Tnbc treatment has huge potential. The market share is over $800 million, and close to 1/3 of that is in metastatic Tnbc. Of all current treatment, our biggest competitor is atezolizumab in combination with nab-paclitaxel due to their similar indication and market share. Let's see how they compare to each other. Both combinations had very similar trial design. Pembrolizumab included patients who received curative treatment 6 months or more prior to the trial, which is much shorter than atezolizumab's combination, which required 12 months. However, atezolizumab reported overall survival outcome data where pembrolizumab did not. From the clinical trial, we can see that Neochuda Duo has faster eligibility for certain patients. However, there's incomplete outcome data. In the future, clinical trials can enroll more females of African descent because they're at a 3-fold risk of Tnbc. And in terms of indication, the two combination requires different tests and values of PD-L1 expression, where more patients would be eligible for atezolizumab therapy. So we have less market share, and because several experts prefer the PD-L1 tests used for atezolizumab, we may lose even more. However, there are several opportunities to explore, including gaining preference for patients with higher PD-L1 expression and additional indications in other subgroups of Tnbc patients. Neochuda Duo has greater efficacy as measured by progression-free survival. From the subgroup analysis, we can also see that younger patients and those in Asia, Europe, America, and Oceania benefited from Neochuda Duo. Therefore, we're winning at efficacy. The two combinations are similar in safety because they do not significantly increase adverse effects as compared to chemotherapy alone. Lastly, Neochuda Duo has lower daily cost and more convenient dosing, which will promote patient adherence. With all the comparison, we're confident that Neochuda Duo will be an extremely competitive product. In accordance with our target demographic, we are marketing our product to motivated younger females who are willing to try newer treatments. They have adequate health literacy and are informed and active in their care. Our key to success depends on these 5 marketing strategies: improving our reach to patient and reputation by partnering with patient support groups and organizations, and creating patient support programs. And also increase prescriber confidence by meeting with practicing oncologists and working with them for guideline creation, and also present our product at webinars and conferences.
Neochuda Duo is a cutting-edge combination therapy from our firm WC Soul Pharmaceuticals, which aims to provide better treatment and improve our patients' life quality. It is classified as an anti-neoplastic drug, and its efficacy is based on the synergy originated by its active pharmaceutical ingredients, pembrolizumab and paclitaxel. It is indicated for Tnbc positive for PD-L1 that has returned and cannot be removed by surgery or has spread. Based on the pharmacokinetic profile of each drug, Neochuda Duo should be administered once every 3 weeks. Each session, Neochuda Duo should be administered as follows: pembrolizumab vial 200 mg IV over 30 minutes, and then 30 minutes later, Paclitaxel 200 mg per square meter IV over 3 hours. The pharmaceutical form and strength of Neochuda Duo consist of 2 vials in each box. Pembrolizumab 100 mg per 4 ml IV solution, and Paclitaxel 30 mg per 5 ml IV solution. Each box comes with an information insert containing specific information and details such as precautions, warnings, contraindications, and correct use that should be checked by the healthcare professional. Patient counseling information. The healthcare professional must inform patients of the risk of immune-mediated or chemo-related adverse reactions that may arise by taking the product and may lead to discontinuation or disruption of treatment. Advise patients to contact their healthcare provider if they show signs as pneumonitis, new or worsening cough, chest pain or shortness of breath, colitis, diarrhea or severe abdominal pain, hepatitis, severe nausea or vomiting, easy bruising or bleeding, endocrinopathies, type 1 diabetes mellitus, hypothyroidism, nephritis, and severe skin reactions. Additional information for healthcare providers include embryo-fetal toxicity, advise females of reproductive potential about the potential risk to a fetus when treatment with Neotruda Duo is undergoing, lactation, inform females to not breastfeed during treatment with Neotruda Duo and for 4 months after the final dose. Laboratory testing. Advise patients of the importance of keeping up with the scheduled appointments for blood testing or others. The General Risk Management Plan procedure for healthcare providers include high-risk events like wrong administration, leading to drug misuse and affecting the patient treatment and efficacy of the product. To avoid this event, a thorough revision should be made to the insert inside the product. It contains the detailed information on its way of usage and administration details. Patient adherence compromised. Patient counseling must be done in order to inform the patient about all the possible side effects, tolerance, and risk-benefit ratio contemplated in the administration of the drug. Run drug dosage or drug product given to the patient. Pharmacists must always double-check the products before preparing them in the IV room. Nurses and physicians should also double-check the labels and information of the product before administration.
Neotruda Duo. Empower your choice with innovation.
L'innovation en vigueur vos choix.
Dale poder a tu elección con innovación.